Good evening, everyone. Welcome to the 7th Jaipur Surgical Tutorial Masterclass. For those who are going to attend and watch this program for the first time, just a brief introduction about Jaipur Surgical Tutorial. This is an online educational portal which we started about 2.5 years ago after I moved from SGPGI Lucknow to Mahatma Gandhi Hospital in Jaipur. And all the educational activities of JST are being coordinated by my colleague, Dr. Anand Nagar, who is an associate professor of HPB surgery and liver transplant at my new institution. And the technical support is provided by the team of Dr. Avinash Tank at Dwarika Clinic in Ahmedabad. So we conduct a session every Saturday morning 9 to 10 a.m. where students present cases or operative surgery sessions and they are moderated by faculty. So that is going on. In between the sessions, I'll project a slide which will show you how to join Jaipur Surgical Tutorial if you are not already a member. But in addition, we thought that we will conduct these single theme master classes. So the videos of all the previous 6 master classes which have been recorded and edited and prepared by Avinash's team of Himanshi and Kripa, they are available. I will post those links also for those who are going to attend for the first time. So this masterclass today and tomorrow, the topic is post-cholecystectomy bile duct injury. And we have almost everyone from the country who has been involved and who has contributed to the management of post-cholecystectomy bile duct injuries. Most of the panelists are from SGPGI, where fortunately or unfortunately we had collected world's largest single institution experiences with the management of both acute bile duct injury and post-cholecystectomy benign biliary stricture. So in this masterclass, we are going to discuss only the immediate or the acute bile duct injury, not established biliary stricture. And to moderate this session today, I have requested 2 of my former colleagues from SGPGI, Dr. Sikora, who has made invaluable contribution to the theme of safe cholecystectomy and management of bile duct injury, and who's currently at Sikora Hospital in Bangalore. He's the president of the Indian Association of Surgical Gastroenterology, and Dr. T.D. Yadav, who's currently at PGI Chandigarh. He is the secretary of the Indian chapter of the IHPBA, and again, his contribution has been in biliary surgery, both bile duct injury and gallbladder cancer. So with those words of introduction, I hand over to Dr. Sikora and Dr. Yadav to moderate this session. Sadiq.
Good evening. Thank you, Dr. Kapoor, for once again inviting us on this masterclass. And good evening, TD. So today, together, we'll try to sort of swim through this session, and hopefully we'll have a lot of interactive questions in this. So the first one is our former colleague, Dr. Biju Pottakkat, who is now a professor at Jaipur, Pondicherry, professor GI surgery and head of department. So he's going to speak on when you see bile during cholecystectomy, what to do and what not to do. So Biju, without taking much time, let's start with this.
Thank you, sir. My slide is visible?
Yes.
Good evening and thank you to all. And it's my privilege to have the opportunity to express my thought in front of such a high-end and highly experienced senior colleagues who have immensely contributed to this bile duct injury and issue of safe cholecystectomy. So I'll just share my some thoughts in the next 15 minutes. So when you do a cholecystectomy, when you see a bile or a suspected situation, first we recognize what is abnormal and what is normal. So when you see a bile, what is probably normal is if you have a bile leak from a positively identified cystic duct or from a positively identified liver bed small ducts, it may be normal. Still, I'm telling you, it may be normal. But what is definitely abnormal is a golden bile in the field appeared anytime Even if it appears and then disappears, it is abnormal. And clips or sutures placed in the common bile duct area, and in an attempt when we do cholecystectomy, sometimes we see bile leak and you place clips and it disappears. That is also abnormal. Why this approach is required? Because in bile duct injury, generally we follow a sensitivity approach. We do not want to miss anything. Even if it turns out to be no injury later, missing a bile duct injury is not acceptable. And literature also says that bile duct injuries, a good number are not recognized or ignored. Now, when you see a bile leak, what exactly is a bile duct injury? So again, when we do a sensitivity approach, not to miss approach, any bile stain during or after cholecystectomy should be considered as a bile duct injury. This is one of the most important message we have to communicate all over. One of the issues we are facing in the definition of bile duct injury is missing the diagnosis and detection of bile duct injuries with the classification systems. This should not be done. There are injuries which are not within the ambit of the classification. That's why there are 20 plus classifications, and any bile detected during cholecystectomy should be considered as a bile duct injury, which can be proved otherwise later. So for the purpose of this discussion, I normally approach the bile duct injury as open inside, open outside, and closed. Closed is stricture or clipped. Open outside is with a drain. Open inside is bile leaking into the peritoneum. Now, when you see a bile, one of the foremost thing what we have to think is, did this patient have any predisposing factors for this injury? Was this patient at a high risk of injury? Because these predisposing factors significantly contribute to the injury. Whether there was acute cholecystitis, whether the GB was contracted, especially in northern part of India, whether the field was frozen and you try to demonstrate the anatomy, the Mersey syndrome was there, cirrhosis and portal hypertension. So in these patients, when you see a bile leak, this bile leak has more importance than seeing a bile leak in a very simple or straightforward cholesterol, because here the chance of injury is more, and even if you see a drop of golden bile, that is usually a problematic area. That will usually end up in a bile duct injury later. Now, what we commonly advocate is a safe dissection, critical view of safety, and all the benchmarks of anatomical landmarks of the dissection. But sometimes what we also have to see in the operative field, when you see a bile, is did we do excess anatomical dissection? So in the left-hand field, you can see that we thought it is a cystic duct, but a cystic artery, but ultimately it turned out to be the right hepatic artery. So if we did already an excess dissection and seeing a bile on table, what we have to assume is there is a very high chance of bile duct injury in this patient, just because of the fact that we have done an excess, unnecessary, proper anatomical dissection delineating the arteries and ducts. So this has to be avoided. And if you see this sort of picture on table and a bile, you can you have a very high suspicion of bile duct injury. So when you see a bile, what are the points which should go through your mind? One is, will you call a colleague? This part Dr. Ajay will discuss later. Will you talk to the relative about the bile duct? Before doing anything, stop and think all this. That's what my advice. And will you, and if yes, how will you assess the extent of bile duct injury? If you see a bile on table, how will you rule out other injuries with a reasonable certainty? Will you, and if yes, when will you perform a primary repair? Are you okay to do it? And what else you do if you don't do a primary repair? So the moment you see bile on your screen in laparoscopy or intra, these are the points you have to think, take a break for 5 minutes, think it, be ready with the answers for all this. That is what the one of the first thought process, philosophical thought you have to keep in mind when you see a bile on table. Now, Another common problem we try to rectify always in any session related to bile duct injury is the word bile duct is actually underestimate the extent of the problem. Okay. So it is not this injury is something beyond the CBD problem. It's not just some rent in the CBD, because this injury can throttle the liver. We are actually injured the excretory outlet of the liver. There is a permanent traffic jam there, or traffic jam can be formed, and this bile is leaking into the peritoneum instead of intestine. So it is not just like a common bile duct stone or other CBD problem. It's actually, rather than CBD, it is now we landed up in a problem of the liver. So this is one of the important differentiation. We have to make our mind that when you have a bile on table, now that surgical part you are converted into a liver problem rather than a common bile duct problem. Now stop and think about the patient. So this patient came to you for a simple gallbladder problem. You told him 50,000 to 70,000. And now what happened on table, if you say bile duct injury, majority of the situation, this has been converted to another complex HPP problem. Immediately, within a few seconds, a small problem blown up out of proportion to a mountain issue of mountains. And the immediate issue what we have to face is, you have always be sure that that patient lost trust on you. That is one of the first important point we have to keep in mind, irrespective of your experience. Normally, we do not explain too much about the bile duct. So loss of trust of surgeon is an important issue. Now, what are the possible risks of bile leak you have to think when you see a bile? Recorded. This can cause death. So a gallstone disease will not cause death normally, but bile duct injury can cause death. There can be reoperation, reintervention, and patients who survive, even if you repair, there will be prolonged morbidity, jaundice, cholangitis, chronic liver disease. And the cost of management of all this, probably this is one of the earlier studies from India. So it is around 10 times than cholecystectomy. So the problem starts in terms of health, morbidity, quality of life, cost, and multiple occasions we have seen that patients who were forced to sell their house and land just to get rid of the issue of management of bile duct injury. So with all this in mind, your mindset should be, first accept the injury, realize that you injured the drainage to the liver, think of the patient, and in the next session, probably we are going to discuss the moral right to repair a self-created injury. Now, another misperception, the moment we start seeing a bile, the common perception, we try to underestimate the problem and think about all the available classifications the literature will take out and try to teach our residents or juniors or sisters that this is this type, that type, and all that. Okay. This is a very bad practice, because neither this is the time to think about classification, nor your classification might be correct, may not be correct in future. Okay. So the problem here is, think of saving the patient and think of saving the bile duct as well. So this is not the right time to think about the classifications. Why this is not the right time? Because this is one of our evidence when we had a large experience in Lucknow. Ultimately, what happens, 39% of the bile leaks or injuries remains unclassified. This remains unclassified, and it closes off, it seals off, or beyond classification. So this is exemplifying the fact that when you see a bile, that the least thing you should do is try to classify it. Self-management, put it as a last option. Are you an experienced SPB surgeon? Do you have all these facilities? And especially surgeons think of these gadgets and all. If you don't have, it's better not to repair at that time. Always better ask a colleague to have a look, even if he's your enemy. Call a surgeon first and not an endoscopist. Okay. One of the important thing, probably we make it wrong is we always think about an endoscopy which is going to put a stent in the bile duct. This is a surgical complication. Here, the first opinion has to be from a surgeon. Call a surgeon, then make a decision, record the injury, and the record is second opinion also recorded who came to operation theatre. In this era of litigation, it's always important to record the second opinion. This will really save you in courts and other further consumer forums and all that. Now, what to do with the gallbladder? So you may be in a situation where gallbladder is intact, partially dissected and bile leaking. If you're not planning to repair yourself, leave the gallbladder as such and do not attempt to complete the cholecystectomy, because this can further damage, further devascularize the area. So leave the gallbladder intact. One important reason is this will help the next surgeon to manage the patient in a better way. Now, another common wrong approach is we try to dissect and delineate the injury further by retracting, by dissecting, and by hooking, by suturing and all that. This should not be done if you don't have a sufficient expertise. The reason is, now once the injury happens, it can be because of the cautery, it can be because of the scissors, it can be because of the any other instrument, but there is a significant possibility of devascularization of the injury. So the pericholecystic plexus as well as the other left and hepatic artery and supracholecystic plexus very important in the further repair and management. These are the arteries which actually feeds the stricture in future. So never try to dissect further in and around the bile duct. So why you should not dissect? Because most of the retrospective evidence show that one of the very important reasons for bile duct injury, bile leak, is the wrong perception. So if you have a wrong perception during cholecystectomy, there is no reason why your perception should be correct during further dissection or repair. So a wrong perception already happened during cholecystectomy. That perception may likely to happen in the further repair also. So don't dissect too much. Now, just don't go and convert just like that. Why it should not be done? Because just to diagnose injury, you should not convert. As I already told, you have seen an abnormal bile. It is a bile duct injury unless proved otherwise. If further plan is not clear, don't convert. And even if you're planning a repair, be sure that you should have sufficient expertise and gadgets to do a small duct repair. Otherwise, just drain the subhepatic and come out. So tubing the hole, sometimes you will be seeing the hole in the field below or above or blind holes. So aim has to be very clear when you tube it. Cholangiogram, it is fine. But normally these tubes will slip out later and it won't help much in making it an external biliary fistula. So the usual thought process after you see a leak is just name it as, okay, it can be from the duct of Luschka. The duct of Luschka is very commonly mentioned beyond its possible anatomical existence. Let us say it is 3%, at least 20 times we might mention a duct of Luschka during cholecystectomy. And don't try to put gauze, sponges and mop at the leaking site. And even if you put a drain and later, don't think that it is going to subside just like that. And don't try to simply blind list. These are the 4 things you should not do when you see a bile leak. So initial simple thought process will be close weight, open inside, make it open outside and wait. So here is a situation where it is open inside. And the minimum you should do is make it open outside. Now we have time and experts can make it right. It is not mandated that you should make it right. We have experts to make it right. And the initial part should be avoid mortality and control sepsis. So the key for all bile leak on table, whether you identified it, not identified, is draining the subhepatis. It's not exactly draining the injury or near the injury. It is the draining subhepatic. Important thing is that is the lowermost point in supine position, the abdomen, and that is where it is going to collect. Most of the sometimes what we see is you put the drain in abnormal positions. There will be biloma there in the epigastrium and other areas. Drain is there, but not in subhepatic. This should not happen. So please remember that our aim is not to drain the collection. Our aim is to drain the collection as well as drain the making it as external fistula. So the critical drain is subapital drain. Other collections are going to resolve. So intraoperative ERCP, if you are very sure, surgeon, endoscopist, both are clearly experienced, you can try to stent it, but in a very minimal proportion of bile duct injury, bile duct type, injury types only, it will help. Now, the intracholangium may help to detect a bile leak. It may identify the site. It may identify the anomalies as well. So, if you have a facility for intracholangogram, use a small DJ tube or small stent, cannulate and do a cholangiogram and see it. But this is also important only if you are planning to repair. Just diagnose and your ultimate plan is referral. This also is not going to help. Two problems we have to remember is injuries are more in degree than anticipated or seen on table, and this injuries gets upgraded with time. So at that time also there are three situations. You identify injury, let's say 1 millimeter injury, it can be 3 millimeter at that time, it can be 10 millimeter after 6 months. So early repair, you have to carry a lot of conditions have to satisfy when you are looking for early repair. Otherwise, the safest approach is think and plan for a delayed repair. Now, when you decide on the repair, you should have all this in hand: retractor, gadgets, adequate assistant, cholangiogram, small loop, and post-operative unit. So, another important thing we forget is we think that we can repair it, we repaired, and then don't refer. Okay. Refer for repair than the repair refer. If you are any time thinking that, okay, you can refer after repair, that is a bad idea. Refer for repair rather than repair and refer. And there is a difference in the, if you now you opted for a primary repair or biliary canastomosis, there is some difference you have to keep in terms of biliary stricture repair and acute bile duct injury. Biliary stricture repair, we do not do end-to-end repair. It's a functional end-to-end, but technically it is a side-to-side anastomosis like this. Okay. But in this acute bile duct injury, normally you will end up in a end-to-side anastomosis because these bile ducts will be very small. One of the important points you have to remember when you do a primary repair is the pericortical tissue, as I mentioned, is very critical for the blood supply. So if you end up in doing a primary repair, your dissection should be right outside the portal vein or hepatic artery. The bile duct should carry a thick pericortical tissue along with that to ensure that the plexus are intact and you do not end up in very thin bile duct. And direct end-to-end repair is also feasible, provided that you should have sufficient expert. If it restrictures, your endoscopy should be able to stent and dilate like a low type 1 or type 2 bile duct stricture. But at the same time, ensure that you have adequate loop and other gadgets for this. And ultimately, in summary, we are looking for key answers when you have a bile leak on table, when to self-manage, when to defer doing anything, and when to refer. These are the three key points I want to emphasize, that at the end of seeing a bile leak, if you decide at least opt one of these three, preferably the third one, that will be a good idea to manage bile duct injuries. Thank you very much for the kind attention.
Thank you very much, Biju. So let me invite Dr. Yadav for your comments, and we'd like to hear from you about this topic.
Thank you, sir. Most of the important point Dr. Biju has covered. So I personally feel we can be a little bit more precise that if you are doing laparoscopic cholecystectomy and you find that bile is in the field, so then you have to decide whether you are competent and trained and your system is also having all the facilities what Dr. Biju has said to manage a bile duct injury, or you are working in a center, even if you have some experience, are you having all the gadgets where you can manage a bile duct injury once you go and try to identify and try to see the grade of the injury. So if you are doing laparoscopic cholecystectomy and you are working in a best center, everybody can have a bile duct injury. So then probably one has to think about doing intraoperative cholangiogram laparoscopically and trying to look into the system, whether it is as Dr. Biju says, sectoral injury, or it is injury to the main duct. If it is a sectoral injury, is it communicating with the main system? If it is, then probably you can put a clip or like take a suture. If it is not communicating to the main system, which is type Strasbourg type BRC, then you have to see what is the size. And if it is very small, you can still get away with the clipping or putting some sutures. If it is not, then probably then you have to think that I am going to convert and do some sort of biliary or cholangioenteric anastomosis. But if you are working, as Dr. Biju is emphasizing, working in a center where all these facilities of magnification and retractor and expert surgeon, HPV surgeon is not available, then probably if you have not taken the gallbladder, don't do anything, just put a drain and refer. Even if you have tried to taken the gallbladder out, so if you are suspecting bile duct injury, no need to dissect more, because damage would be more if you are dissecting more. And just to convert to just document that I have done a bile duct injury is also not justified. One important point, Dr. Biju, I think you emphasized, but like as you say, then once you have put a clip and you are proceeding further dissection and you are finding another duct, what you call is second cystic duct or sectoral duct. So one has to keep in the mind that the first one was the common bile duct, and second one is probably the main cystic duct. So these are the certain finer points by which you can be your suspicion should be more when you are having these ideas in the mind, that suddenly after doing some dissection you are finding this type of this thing. Third important point is when you are cutting you have support, you have ligated and cut it, and if it is falling back, dipping towards the duodenum, it means common bile duct has been cut. But if you are after cutting and you are seeing that your cystic duct is going and going down, it is parallel to the direction of the common bile duct, probably 90 degree or something like that. It means that you have done not done the bile duct injury. These are for the difficult cholecystectomy, where, as Dr. Biju said, in group certain percent of the patient you are not able to. You won't be able to really have a critical view of safety. Then one more important point, that if you are not able to create a critical view of safety, then if it is funnel-like opening of the cystic duct in the gallbladder, and you can probably dissect more carefully without doing any energy source and going to the Hartmann's pouch and trying it, this cystic duct going and being a funnel, widening toward the gallbladder, then probably leaving little bit cystic duct and clipping there might save bile duct injury. And regarding management, most of the points have been highlighted, and one has to really if one wants to really repair, then all those points which has been said by Dr. Biju should be taken into account. Most important is, if you are using this harmonic scalpel and all those instruments, then even bigger vessels can be coagulated, and you probably miss the right hepatic artery or something. So if you are trying to repair on the on table, then even the reports are that even HPV surgeons, their outcome with the intraoperative hepaticojejunostomy vis-a-vis delayed repair outcome is poorer in a intraoperative this thing. So these are important finer points. I thought, okay. Thank you, sir.
Thank you very much. Thank you for your inputs and all. So let me just in a way summarize the important points which you have made, Dr. Biju. I think you made the point that the type of disease is very important because it is high risk for injury. So when you see bile, I think we got everything together in this, although the topic has been broken into who to repair and how to repair and all that. But if we concentrate only on bile seen during cholecystectomy, as you mentioned, the abnormal and normal bile, you have to distinguish. I think central or peripheral leak is important. If it is coming from the hilum or from the hepatoduodenal ligament and it's golden bile, you are worried. If it is identifiable leak, you can sometimes, you have nicked the gallbladder. Most of the time do 40% of time there is a hole in the gallbladder and there is bile leak. And if it is identifiable, it's good. You don't need to panic and continue to do what you have to do. But a difficult gallbladder, central bile leak, which is golden bile, and it is during the time of dissection in the area of hepatocystic triangle, those are the times when you should be worried, as you highlighted. So the second important point which you said it, what not to do. So do not remove gallbladder if there is high suspicion. Do not dissect CBD if there is high suspicion. Do not convert only for the sake of identifying the injury, and do not tube. I think these are very important points which we need to remember what not to do. One of the things is when to identify that it is a major bile duct injury and not some peripheral injury. So site of injury and timing of when the bile is seen at the time of injury is important. But if it is unclear, I think that is the point you may want to do a cholangiogram. Of course, you need to have facility, and we have to make sure that in trying to do a cholangiogram, you do not worsen the type of injury. So if you have all facilities, then you do a cholangiogram, define the injury, and then take steps accordingly. But if you don't have facility, and if it is a high degree of suspicion, then you follow the algorithm as Dr. Biju has highlighted. I think the last 2 points which you said, defer and refer, are also critical words and terminologies which we should keep in mind for all concerned, whether experienced, inexperienced, in a peripheral place or in a tertiary care center. Because at every stage, based on what kind of injury it is, you may choose to defer and you may call somebody else to do it, which we'll discuss in the next talk. So let's see if there are any questions. Yes, Dr. Kapoor.
So just a few points. So of course, they will all be repetitions, but I think they are important, so I would repeat it. And my comments are basically for our target audience, which I presume is general, minimally invasive, laparoscopic, non-biliary surgeons. So these comments are not for anyone in the audience who is a biliary surgeon. And my definition of a biliary surgeon is any of us who does a biliary enteric anastomosis as a routine, frequently and regularly, not once in a blue moon. He or she is a biliary surgeon. So my comments are not for a biliary surgeon, but for a non-biliary general surgeon. First is the magnitude, as Biju said, that a plain, simple, short stay, easy, good recovery operation gets converted into a major complication that every one of us has to understand. And we have to be careful on that. That, of course, is a separate topic, how to prevent it. Second is that any bile leak is a bile duct injury unless proved otherwise. So intraoperatively, if bile is seen, it should be considered as a bile duct injury. How do you prove it? I think the word he used, that take a break. And I always say bile during cholecystectomy is like the yellow signal on the traffic light, which means that you have to stop, look here, look there, and then only proceed. So how do you differentiate between CBD bile and gallbladder bile? CBD bile, as Dr. Sadiq said, will come during the central dissection, in the Calot's triangle dissection. It is thin, watery, golden yellow in color, which flows freely on the tissues. Whereas gallbladder bile is thick, viscid, greenish yellow in color. Sadiq, the questions on chat will come from the audience will come on chat. Hemanshi would you send the questions to Dr. Sadiq? Yeah, you've already sent it to me. Maybe send it to Dr. Sadiq directly so that he can take them up. So that is important. If possible, take another opinion so that you get a fresh, unbiased opinion. The person who comes in the theater at that time is not suffering from the visual perception error, which you may be suffering from. Very important is this: do nothing. If you are not competent to handle a bile duct which is undilated, normal sized, a few millimeter in diameter, do nothing, which means no cholecystectomy, no cholangiogram, no T-tube, no repair, and no hiding this complication from the records and from the relatives, because that is one of the reasons for a medico-legal problem later on. The role of endoscopist comes in the post-operative period, where you have a bile coming out and you want to delineate either the anatomy, for which MRCP is better, or you want to drain the bile duct in order to control or decrease the fistula output. So these are some points which I thought need repetition. Sadiq, I've got the questions here, so I'll read them.
Please.
Dr. Tetraj from Mauritius, he's been a visitor to India some time ago. He says, in case of a lateral CBD or CHD injury, is T-tube placement via the injured side and suturing the rent, or choledochotomy? So whether to put the T-tube through the rent or through another side, and how do you close PDS 40 interrupted? What is your opinion about it?
So when you say a bile duct has to be identified. So first point is bile duct should not be dissected during cholecystectomy. That is the first important point. Now, to identify that that is the bile duct, you need a cholangiogram. That is the point number 2. So if you positively identified that is the cholangiogram and you are the expertise, laparoscopy expertise to suture it in a reasonably good diameter duct, you attempt it, but at the risk of stricture. Again, the stricture. Now, one important point here is these are the injuries. You think that it's a type A injury, but these injuries can be stented endoscopically also with equal success. So endoscopy is a transpapillary without further damaging that area. So think whether that is the best option, or again meddling with that area, dissecting it and suturing is another option. To suture it, some dissection around the bile duct has to be there. And probably if you don't have much expertise, I advise not to do anything. Cholangiogram and think of possible YASI.
So if any of the panelists would like to make some other comment, we have about 2 minutes before we move on to the next topic.
So, I would like to ask Dr. Sadiq. Sir, suppose if surgeon sees bile during lab chole while doing lab chole in his OT, and if the surgeon wants to decide the patient to be referred to you, so what are the pointers which would you like to have then in the referral note? But what kind of referral note he should say? What all points he should include while referring it the patient?
So let's
before Sadiq answers, let me introduce Dr. Abhinav Sharma. Is a leading gastroenterologist in Jaipur. He is again an SGPGI alumnus. Yeah, Sadiq.
So, I mean, I'll ask Biju also to say, but see, I think that's a very important point. We need a complete operation notes, wherein that at what time and how much dissection was done and what was the condition of the tissues at the time when they saw the bile and the stage of dissection. I would say that if there is a recording available, I would like to get the recording. And actually, you would be surprised at the number of times which they are able to provide that. So, often we feel that nobody records and all. Yes, perhaps 50%, 60% don't. But if 30, 40% do record, I would like to have that recording, because that gives you a full information of that. The third thing which I would want to know, if the recording is not there, was there any bleeding which was significant enough for them to do something. Sometimes they forget to mention that. And in that situation, you don't keep in mind whether there is associated vascular injury or not. So the operative findings in detail, whether there was any significant bleeding which required control, and the nature of the disease which they encountered, if it is an acute thing, at what stage they did the cholecystectomy. And finally, as I said, the most important thing, if it is available, is a video recording, because it has made a big difference many times that I have faced this situation. Biju, TD, you want to add something?
Biju, you are muted.
No, nothing to add, sir. That's...
Biju, one last question from Dr. Vishal. He sent it to me directly. Vishal Gupta, he is the chief of GI surgery at AIIMS Bhopal. He's also contributed a lot to safe cholecystectomy concept and philosophy. He says if the cystic artery has already been clipped or divided, then can we leave the gallbladder in situ? Is there a risk of necrosis?
No, there is no risk of necrosis if it is not detached from the liver bed. It will survive. So, because the acute cholesterol, other issues won't happen because you already divide the cystic duct. Now only collected bile or some leaking bile will be there. It will get perfused, no risk of perforation. So it can just be left alone.
And moreover, we are doing this in a situation where you are referring. So something you expect the referring doctor to be doing, minimally a laparoscopy, and at that time, assessment and removal of gallbladder. So I don't think that's
not necessary that after referral, the patient will be operated.
No, but if the patient goes and is referred and the gallbladder is in, I think it is imperative that at least the person A will assess the injury, and B, we need to get the gallbladder out. We can't leave it interminably.
Okay, I think we can move on to the next. Yeah, Abhinav, you want to say something?
No, sir. My question is answered.
Okay.
Thank you.
In the meantime, Biju, if you are still there is a question from Dr. Nabeen Padial in the chat. Maybe you
Yes,
can.
Yes,
There is
yes.
a question from Nepal, which I will request
Yes,
Biju to
please.
take.
So is it regarding the how to select cases for cholecystectomy for the beginners? Probably biliary colic patients with biliary colic, ultrasound, no contraction of gallbladder, distended gallbladder, no other predisposing factors, and most importantly, put the scope in the presence of a senior and see, then proceed. That is the best thing. Put the scope and then decide whom to operate. That's what even now with I think most of the teaching centers do. Despite assessing the simplicity of the surgery or difficulty beforehand, we decide who will do only after putting the scope and see the situation. That's a very important point.
Yeah, I will just add to it that avoid all the risk factors or predictors of a difficult gallbladder, and that, so which means young patient, female patient, thin-built patient, only biliary colic, no acute cholecystitis, no long history, no acute pancreatitis, no CBD stone, normal LFT, distended gallbladder on ultrasound, thin-walled gallbladder. If you avoid all the other risk factors which predict a difficult gallbladder, most probably you will have a simple or virgin gallbladder. And as Dr. Biju said, if you have the facility that you can call for help after putting the scope, then obviously that is the best time.